Welcome to the screencast on counselling clients who present with co-occurring conditions. We're interested in co-occurring conditions because it's fairly common to see clients present with mental health issues along with their SUD. So some of the data that's come out of Lade and Huang indicate that 35% of clients who are relying on a substance also present with a mental health issue. The most common presentations are anxiety, depression, personality disorders, with anxiety being the most common. And there's also alcohol-related brain impairment and dementia, which is seen when there's been severe and prolonged substance misuse. And what's also come out of the data is that PTSD indicators tend to be very pronounced for clients with SUD, and that aligns with the theme that we've looked at throughout the module this term. So when we look at this term comorbidity, what does it mean? Often you'll hear the term dual diagnosis used, and we try to move away from this because it tends to be very overgeneralizing and does not give us a sense of client presentation in terms of the severity or duration of co-occurring conditions. Many people who present with SUD issues display mental health issues also, but they don't necessarily meet criteria for a DSM-5 diagnosis. Having said that, their struggle with mental health issues along with SUD issues really exacerbates any sort of mental health concerns that they have, and you can really see this emerging in functionality for the client. So rather than viewing mental health as being either present or absent in terms of a disorder or indicators, mental health conditions can be viewed as occurring on a continuum ranging from mild to actually acute presentations. So zooming into this alcohol-related brain impairment or brain injury, it's caused generally by binge drinking, long-term high-risk drinking substances like methylated spirits when alcohol isn't available. So we are seeing it present more in Indigenous communities. It can be caused also by poor nutrition, poor absorption of vitamin B1, and then the toxic effects of alcohol on the brain, dehydration, or accidents that cause head injuries. So it impacts cognition, of course, short-term and long-term memory, physical mobility, and can cause dementia-like symptoms. So whilst we don't hear about it very often, the Victorian government has run studies that estimate that up to 200,000 Australians live with an undiagnosed form of alcohol-related brain impairment. So let's look at why comorbidity occurs. There's a number of possible explanations depending on your framework around SUD also. So firstly, it could be the presence of a mental health condition that leads to substance use or vice versa, and this is called the direct causal hypothesis. So we know that some people who perhaps have early onset use of cannabis, alcohol in adolescence, then and that's coupled with predisposition to mental health issues, then develop a more acute presentation of mental health issues. Number two, there might be an indirect causal relationship. So an example is early AOD use may lead to, say, dropping out of school, which leads to low employability, which then generates a sense of depression and displacement for the client. And thirdly, there may be factors that are common to both the SUD and mental health condition, which increase the likelihood. So that could be transgenerational transmission of AOD and also mental health conditions. So, zooming into co-occurring conditions, we know that psychotic episodes can be triggered and even exacerbated by the effects of a substance. Marijuana is known to trigger panic attacks and anxiety for some users. And the use of methamphetamines like speed ice, crystal meth, shabu has increased the incidence of psychotic symptoms such as delusions and hallucinations and paranoia, almost schizoid affect type indicators. Risks associated with injecting drugs include Hep C, HIV. So dual primary diagnosis, sometimes a mental illness and substance abuse are both present, and neither appears to have caused the other. So this may be because of risk factors for developing both conditions are the same, or there's some genetic vulnerability that contributes to both conditions. They may still interact and increase risk of relapse. So this is where an integrated approach to counselling is required, which combines both treatment of substance use, perhaps abstinence or harm reduction, and also supporting the client around their mental health presentation. An assessment that's comprehensive is really required. We need to establish the order of onset and which condition is primary. And this can be really, really challenging. Counsellors need to work with the primary diagnosis first, ideally. So a comprehensive developmental history needs to be taken so that we can get a sense of the client's earlier life. And this is where the 5 Ps model would come in to play, because we're looking for precipitating factors. It's useful to understand the relationship between the conditions. So once comorbid conditions have been established, it's most likely that the relationship between them is one of mutual influence rather than being isolated. So regardless of how the comorbidity came about, both conditions may serve to maintain or exacerbate the other. So they kind of feed into each other or become fused. So an example is a person may engage in substance use to reduce symptoms for anxiety. However, research suggests that repeated use only exacerbates and makes that anxiety more prevalent for the person. Personality disorders are really interesting. In my practice, I've supported lots of clients who present with trauma, borderline personality disorder, which is a diagnosis they've received from a psychiatrist, and who are also relying on substances. They seem to be really common among alcohol and other drug counselling, particularly opiate use. Antisocial personality disorder was found in 62% of clients, and borderline was found in 47% of clients, according to Ross and All's study. So DBT becomes a model that's really relevant to this client group. It was specifically developed for working with borderline personality disorder, which is a relational disorder that within the field is known to be a personality disorder that is generated or grows out of, acute trauma, and generally relational trauma, which we looked at in the workshop. So longer term psychotherapy is integrated with SUD work for achieving the best therapeutic outcomes for this group. Because it is relational in nature, it does require a long-term engagement of the client. Shorter-term interventions don't necessarily facilitate change because some patterns are really, really entrenched and create a lot of relationship problems with self, but also others. So some of the things we're wanting to cultivate for clients is self-compassion, to do some capacity building around emotional regulation, in particular anger. Counsellors can provide security and avoid triggering angry outbursts by making, predictable, structured sessions and being really respectful. Empathy absolutely impacts a client's shame around both mental health and also their SUD use. We're also wanting to really establish a very strong therapeutic relationship. In the absence of specific research on comorbid disorders, it's generally recommended the best practice is to use the most effective treatments for each disorder. So in this case, we've determined this term that MI is really powerful in terms of supporting clients around change with their SUD issue, and that would be evidence-based. And then trauma-informed practice is also evidence-based and will allow you to support clients that present with far more complex presentations. And the research indicates that pharmacology can also be very useful in terms of supporting clients while they're in treatment. So different approaches to treatment, because I think this is one of the trickiest things about counselling clients that present with co-occurring conditions. It's how do we go about prioritizing? And for me, it's about really inviting the client to be part of that goal-setting process and part of the process of identifying what is practical for them in terms of helping them to stay safe. So sometimes, prioritizing a suicide safety plan or a self-harm reduction plan is a priority. And then looking at SUD because it's immediate, it might be impacting relationships. So really looking at harm reduction around that, and then looking at trauma. So these are the different intervention levels. So there's sequential treatment, where the client is treated for one condition first, which is followed by treatment for the other condition. So with this model, the SUD is typically addressed first because it's practical and we're wanting to reduce any risk around that. Whilst we're reducing SUD, we're wanting to build safety and rapport in the counselling relationship and a sense of self-efficacy for the client, that they can actually address perhaps their trauma or other mental health issues. Parallel treatment is where both the SUD and the mental health are treated simultaneously. So treatment for AOD use is provided perhaps with one treatment provider, whilst mental health condition is treated by another. So at times I have worked with clients who are attending Quinn, for example, and doing some group therapy around their SUD. We might kind of touch on it and talk a little bit about that work, but primarily they're seeing me for trauma processing. Then there's integrated treatment where both the client's SUD use and mental health condition are treated simultaneously by the same provider or same counsellor. So I've been in that situation as well, where I'm kind of journeying through both recovery with the client and also doing trauma processing. And that's probably the most challenging. Then there's stepped care, which means the flexible matching of treatment intensity with case severity. So the least intensive and expensive treatment is prioritized, and the more intensive or different form of treatment is offered only when less intensive forms have been insufficient. So for me, that's about